A very good evening to all of you. We are going to talk about prevention of type 1 diabetes today. Where do we stand? So we know that there is no conflict of interest as far as this presentation is concerned, and this is how we're going to discuss this entire presentation today. Definition of prevention of type 1 diabetes. As to what do I mean by prevention of type 1 diabetes. And then there are different levels of prevention that's there, type primary prevention, then secondary prevention, and then talk about whatever data currently is from largely from the Western countries, and then is it really applicable to Indian context, and then a little bit of effort on our part at our center and with help of speed organization as to what we are doing as a part of tertiary prevention for type 1 diabetes. So we know that type 1 diabetes is a disease which, although does not have very high prevalence, but still impacts not only the child who's been affected for rest of his or her life, but also it impacts the entire family. There are enough studies which tells us that the financial, the the health, the psychosocial impact of type 1 diabetes is huge on the entire family, not only the child. So if you want to prevent any disease which is chronic in nature, so there are certain criteria that need to be fulfilled. These should be of sufficient health concern. There should be a population which we can screen, which we can identify easily, and then we should have a strategy which, when applied to this particular population, should be effective in preventing that disease. And then this strategy should not only be effective, but should also be practical so that it can now be implemented over larger population level. So whenever we talk about any level of prevention, and all that holds true for type 1 diabetes also, whether that's primary, secondary, or tertiary prevention, then we need to think about all these factors, and then we need to decide whether our strategy is going to work in a practical scenario or not. So we know that for any disease, not only for type 1 diabetes, but there are different levels of prevention which are there, which are called primary, secondary, and tertiary. Primary is like disorder is actually prevented from developing. For example, a lot of vaccinations that we do in childhood are example of primary prevention. Secondary prevention is that disease is detected and treated early in subclinical stage. In the sense that, for example, somebody doing mammography to detect breast cancer, or somebody doing DEXA to detect osteoporosis. So it's already there, but there are no per se clinical symptoms for it. So we've done an early detection, and then we are going to treat them. We are going to use some strategy to prevent it from happening. And then tertiary would be that disease has already happened, and now we're trying to limit its morbidity and mortality from that particular disease. Coming back to type 1 diabetes, so type 1 diabetes, uh, uh, around in different studies, the estimate is that 1.28 to 2.30 lakh children and adolescents less than 18 years of age are affected with type 1 diabetes are living in India. In US, diagnosed with people who have type 1 diabetes lose approximately 19 years of life. And in Indian scenario, it's even more that we're going to cover in upcoming slides. There is a poor health related quality of life. There is poor quality of life for family. So type 1 diabetes is a disease uh, which is a which is a sufficient health concern for any country for to be happening in its population. Now, uh, type 1 diabetes has been divided into stages according to JDRF. So then the stages are uh, so anybody who's going to have type 1 diabetes, they generally have a genetic predisposition. That's what we believe. Then there is a putative environmental trigger which induces autoimmunity, and then this autoimmunity gradually damages beta cells. Then you get dysglycemia, and then you get clinically onset diabetes. So these have been divided according to different stages as stage 1, 2, and 3. So Pre-stage 1 is that the patient has risk factors. Stage 1 would be that there is a beta cell autoimmunity which is there, and then stage 2 would be that along with beta cell immunity there is a poor glycemic, in the sense that it's not fulfilling the diagnostic criteria for diabetes, but there is a dysglycemia which is present. And then in stage 3, which is full-blown clinical disease, is when your symptoms are present. So stages of prevention for type 1 diabetes would mean that primary, which means pre-stage 1, individuals at high risk of developing type 1 diabetes. Secondary would be stage 1 and 2, where people have beta cell autoimmunity as well as, or plus minus, also have dysglycemia, not fulfilling criteria for diagnosis of diabetes. And tertiary would be when somebody already has a clinical type 1 diabetes. And when we are looking at strategies or how do we act at each of these levels, so at each levels of prevention, we need to identify population at risk. What is the prevention strategy that is being proposed, and then what is the current status of data on each of these strategies. So if you look at type 1 diabetes, any case that happens in the community in type 1 diabetes, 10% of them are familial cases, which means that out of 100 people diagnosed with type 1 diabetes, 10 would have a family history of diabetes, and then 90 would be sporadic cases. Now, for primary prevention, if I need to identify these people, so one obvious cohort is a familial case. And the familial case is that if somebody in my first degree relative, FDR means first degree relative, if has type 1 diabetes, then I am at high risk. And then the risk can further be stratified based upon how many people are affected. As more the number of first degree relatives affected, the more the risk for developing type 1 diabetes is. If the first degree relative has age of onset less than 7 years of age, then there is an added risk of the siblings or the first degree relatives getting type 1 diabetes. And then there is based upon if you do a genetic scoring in these people, which also includes HLA and non HLA genes that we would be seeing in the coming slide. So if you combine all those things, then you get a very high risk. But the problem with this is that this is only going to identify less than 10% of people who are eventually going to get type 1 diabetes. So you're going to identify very small subset, but then this subset is high risk for developing type 1 diabetes in the future. Then the 90% of sporadic cases, can they be identified in the population? Not all of them, but around 50% of them can be identified if we do population level screening for HLAs. So HLA contributes almost 50% of genetic risk, identifies almost 50% of genetic risk for type 1 diabetes. Then these HLAs are being divided into high risk and moderate risk. So if I start screening everybody in general population, and this data is from US, Denver. So when they try to screen, when they screened 5,000 children from the general population, almost 2.8% of them had high risk HLA, and up to 24% had a moderate risk HLA, which means that all these people are predisposed. But then that's a huge number of people that need to be followed up for development of type 1 diabetes. Now, just if we try and see in little more detail, the family history uh, is a risk factor, in that sense that if there is a newborn without any type 1 diabetes first degree relative, then the risk of developing diabetes is around 0.4% or so, and that's in the US. The newborn first degree relative of people with type 1 diabetes has got a 5% risk. Multiple affected FDRs, then risk increases 20 to 25%. And then if somebody's got an identical twin, then the risk is 30 to 70%. So it is said that familial cases account for 10% of total cases of type 1 diabetes, as well as 10% of the relatives by age of 60 years would develop type 1 diabetes. Now, coming down to HLA risk, not only HLA, but the other genes like in the insulin, PTPN22, and then interleukin 2 receptor are also, these gene also contributes towards the increased predisposition for type 1 diabetes. Now, There are various type 1 diabetes genetic risk scores has been developed, which includes your HLAs as well as the other genes which has been implicated in type 1 diabetes. But only question is, do we do all these testing in the general population for detection of type 1 diabetes cases or not? So to predict, just to put this thing in perspective, for example, in US, from where the data is available, to predict one case of type 1 diabetes based on HLA, almost 2,000 children need to be followed up. So because these 2,000 children would have HLA either in moderate or high risk category, and then one case out of these 2,000 children would eventually develop type 1 diabetes. So, what are the strategies that we take? Of course, you cannot change family history or you cannot change genetic predisposition, but what you can try to avoid is that whatever that environmental trigger is, if we can somehow counter that, so then type 1 diabetes can be prevented. But the problem here is that we really do not know what that environmental trigger is. So the potential strategies includes which has been tested: avoiding cow's milk, giving a gluten-free diet, then trying to vaccinate against common viruses implicated in triggering of type 1 diabetes. Then certain general immune modulators have been tried, like docosa hexanoic acid, supplemental vitamin D, and then some data on gut microbiome modifying the T regulatory cells, and then immunity modulators specifically. Now that's an attractive approach, although has not been successful so far, but is considered to be the eventually to be the answer for prevention of type 1 diabetes. We're going to discuss this thing in a little more detail in upcoming slides. So out of these, let me be clear that general immunity modulators have not been shown to be effective at all. Gluten-free diet has also not been shown to be effective at all. Uh, we can look at the data from cow's milk again. A few of the meta-analysis, when combined, data showed that there may be a possibility that cow's milk exposure early in the life can be responsible for developing type 1 diabetes, or the risk is higher in people who take cow's milk. But subsequently, this has not been confirmed in the other studies. Moreover, what we need to also understand is that exposure to cow's milk has been shown to be associated with more autoimmunity, but then that autoimmunity is significant only till development of one type of autoantibody, not two type of antibodies. For example, so children developing two autoantibodies has always been similar in cow's milk or without the other group, and that's a significant thing, because one antibody does not really predict happening of type 1 diabetes in future. So cow's milk has not been consistently found to be a triggering effect. So avoiding cow's milk, it does not seem to be a good primary prevention strategy. Then there is enough data which tells us that the children with type 1 diabetes are affected with or infected with enteroviruses much more than their controls. But the exact nature of virus, the haplotype, the genre of virus which is impacting in these children has not been identified. We've not been able to develop a effective vaccine towards a particular virus which can prevent these infections from happening in children with type 1 diabetes. But that's the approach which is being very aggressively followed, and JDRF this is one of the approach that everybody is doubling down on now. Uh, so it has been proposed. Then there comes something called immune tolerance, as we talked about earlier also. So that has also been called as vaccine. So basic idea is, and we're going to see this thing in subsequent slides also, that idea is that if we induce uh, some T regulatory cells by exposing children with antigens, which eventually might be pathogenic in these children. So then these children, when exposed, and if they develop an immunity towards few of these antigens, like for example insulin, then it has a potential to upregulate T regulatory cells, which can subsequently, whenever beta cell autoimmunity develops, these T regulatory cells can suppress that. So that's the basic principle on which it works, but it has not been found to be effective so far. But because this therapy does not have any side effects, it can be implemented on the larger scale. So people are still looking for more and more antigens or targets by which by using them as vaccine uh, to prevent type 1 diabetes, both as a primary level and then also at a secondary level, which we're going to see subsequently. Secondary prevention we've already talked about is stage 1, when people have already developed autoimmunity, people have already developed dysglycemia. And then we know that autoimmunity is defined as presence of 2 or more islet antibodies to insulin GAD65, IA2, and zinc transporter. One autoantibody may be positive. Uh, it is not a great indicator for development of type 1 diabetes in the future, but if somebody's got 2 or more antibodies, then they're going to develop type 1 diabetes in the future for sure, but then that can have a lag period of 15 to 20 years after they've been first detected with 2 or more than islet antibodies, beta cell antibodies before that. So they generally develop at 6 months, peak at 9 to 24 months. And if they develop less than 5 years of age, if these children have high risk HLA, then the chances of progressing to 2 antibodies is much higher. Although if after detection of first antibody, if children has been followed up for 4 years and then does not develop second antibody, then there is almost no further seroconversion. So if one child has one autoantibody, we need to follow that child at least for 4 years further to see at it. And then there is a great lag period between development of autoantibodies and dysglycemia. Dysglycemia starts happening just around a year to 6 months before the actual clinical onset of type 1 diabetes. So once somebody's got a dysglycemia, then it's a very rapid progression towards clinical stage 3. Now, so although here our target population is clearly defined, so all children which have got 2 or more antibodies, and then their risk can further be stratified by family history, high risk HLA and dysglycemia if it is present. So because there are set criteria for this population. In fact, in high prevalence countries like Germany, they've started a trial called FRIDA study where they are trying to enroll 1.8 million children, and then they are trying to do antibody screening in entire population in a particular area to try to look at as to how effectively children can be screened, and then how effectively can they be secondary prevention strategy can be used in that. So now strategy for secondary prevention largely consisted of targeted immunotherapy. So now we know that it is an autoimmune process, and then the different cog and wheel of these autoimmune process would be T cells, B cells, antigen specific immunotherapy, and then we can target inflammation, and then cell intrinsic metabolism is something which can also be targeted. So this is just a very, very brief overview that our T cells are being made in the bone marrow. In thymus, they get a central tolerance. Then these cells come into the peripheral circulation where they are exposed to beta cells and antigen presenting cells, and they are exposed to the antigen. Then depending upon the identification of self-antigen, then the T cells are activated. And then the activation of this T cell is counteracted by presence of T regulatory cells, which practically suppress them. So there is a counteraction between T effector cells and T regulatory cells. So what we want to do here is that we want to and then these T effector cells, if there are not enough T regulatory cells, then these T effector cells goes to islets and destroy beta cells there. So and then more and more inflammation is produced, and more beta cells are damaged. So different cogwheels here that we want to address is that we can act on these beta cell T cells so that these cells are not activated. So we can have immunotherapies targeted to T cells. We can also have targeted therapies for B cells so that the antigen presentation is impaired and they are not able to produce antibodies further. We can also target inflammation. We can also try to increase T regulatory cells by suppressing T effector cells is one approach, but increasing T regulatory cells can be the another approach. So when we try to target T effector cells, that's where the most recent successes has been found. It include anti-CD3 antibodies, Teplizumab and Teplizumab, then alifacept, which is anti-CD2, and then abatacept, which is CTLA4 IgG fusion protein. Then rituximab for B cells, then antigen-specific therapy with GAD, insulin, pro-insulin and T-regulatory cell infusion per se. Then therapies targeting inflammation include anakinra, senakinumab, and rapamycin and imitanib. Now, only therapy which has been found to be successful is targeting T cells. Antigen-specific therapy, as we a little bit talked about earlier, also is one of the therapies which has been still shown to have some promise, although no success so far. But people are kind of still vouching for it. While B cells and inflammatory strategies has generally not been either have not been effective or has been associated with much more side effects for them to be further used in this field. So coming down to the talk of the town drug Teplizumab. So Teplizumab basically is an anti-CD3, and CD3 is part of the T cell receptor, which kind of interacts with the antigen presenting cells, and then this T cells gets activated. Now, we initially anti-CD3 was made a human monoclonal, but then there was a lot of serum sickness-like symptoms, and there were also cascade inflammatory reactions which were there. So these antibodies were modified to produce either Otelixizumab or to produce Teplizumab. So there are different mutations which are there, and then so these mutations now limit the serum sickness part or the non-specific inflammatory reactions which were associated with monoclonal anti-CD3 antibody. Basically, what it does is that it down-regulates T effector cells in the short term because it does not let the T cell receptor interact with the APC. So then the T cell eventually is marked for apoptosis, while in the long term, because there is still spillover, then T regulatory cells gets time to build up kind of a suppressive immunity for a particular beta cell antigens. So in the long run, the beta cells are preserved. And then effect has been shown a long back. You can see that the mouse islet, the inflammation which was, according to them, was grade 5 once they were treated with Teplizumab. So then their inflammation actually regressed, and then it regressed to almost it's called a peri-islet insulitis, which is there rather than the generalized form of insulitis which was there. And then, of course, it has recently been accepted by FDA as an acceptable therapy for secondary prevention. In a study over 76 patients, it was shown that the lesser number of children in given period of time, lesser number of children developed type 1 diabetes while they were on Teplizumab therapy as compared to people who were on placebo. Although the decline was parallel, but it seems that it at least gave them 24 months gap. So almost 2 years gap, delayed the onset of type 1 diabetes by 24 months is what we can say from this. And then this is the antigen specific therapy that we've been talking about. What it means is that we expose these children to one kind of an antigen which induces more T regulatory cells, and then these T regulatory cells does not let beta cell autoimmunity to be developed. But the idea is that these antigen ideally should be from the same class. what the pathogenic antigen looks like. So that's why insulin, pro-insulin, GAD, these has all been used as as the agents for this bystander suppression, as it is called. Now, the tertiary prevention, the intervention trials in newly diagnosed case, and generally that has been the steer for treatment for type 1 diabetes so far. However, there has been therapies which has been developed. Uh, for example, immunosuppression is one thing that has been tried, and then same immunotherapies which has been tried in secondary prevention has been used in tertiary prevention also. So immunosuppression has been effective but has not been practical. There is significant toxicity. There is no end point, like they are effective till the time they're given, and they are not sustainable in the long run because of all these things. Uh, Teplizumab again has shown some effect, not as effective as in secondary prevention, but some effect is there. And then other antibodies has shown to be effective in few studies and not shown to be effective in other studies. So they are still work in the progress, but they this approach seems to be very effective. Few therapies which does not seem to be work would be BCG vaccine, and then the other anti-inflammatory medicines. People have even tried atorvastatin or sitagliptin in these people, but has not been found to be effective. Now, just to give you a perspective on Indian scenario, India has highest number of children suffering from type 1 diabetes all over the world, but incidence in India is not in the top 10 countries. The country with the highest incidence is Finland, and then uh, uh, but India has the highest number of children with type 1 diabetes. Now, if we try to look at as to what does it mean in terms of numbers, so I've tried to create this table which compares four different countries: Germany, Finland, US, and India, where I've tried to see as to, so India seems to have highest number of type 1 diabetes children. But if you look at the population which is at baseline, so India has 30 crore people less than 15 years of age, while Finland has 8.6 lakh children less than 15 years of age. Germany has similarly 1.07 crore children who are less than 15 years of age. And if you look at life expectancy of a child with a 10 years old with type 1 diabetes, you look at India fares dismal. India's response is dismal. We only got this is about mean age is 20, life expectancy is 25 to 39 years. While the total health spending per capita in international dollars is only $191 per person in India, as compared to the the spent from other countries. Why I'm showing this is that we've got a huge population. We have not been able to treat people who are diagnosed very well because of limitation of resource and wide population. Primary prevention and secondary prevention in India are still going to take a lot of time to be implemented in India. Primary, and secondary preventions are very good strategies in countries like Finland, which has got very high incidence, very small base of children which need to be looked for, and then they are rich enough to have that space fiscally to kind of support this kind of treatment. Now, what just a small word on what we've been doing at our center to kind of help, which kind of by with nature of tertiary prevention for type 1 diabetes is to spread awareness. We have developed a first of its kind diabetic education module, which is just dedicated for children with type 1 diabetes. We've already spread across all over India with almost 50 centers, out of which 35 centers are already functional, and 500 or more people are already under training for care of these children. And then we are also trying to use technology to make life easy for children, which starts right from creating a food database and then trying to give them a carb counting as well as bolus dose prediction, automated, which is kind of learns on itself by reinforcement principle. And we have published this. Our first pilot project is already out, which shows a fair level of acceptability by the people who used it. And in the long run, their glycemic variability has also shown to be reduced by us. Now we are working on the final version of this app in the future. So just to summarize, there is still a long way to go in designing ideal prevention therapies for type 1 diabetes. Primary prevention may be useful in countries with high incidence rate with low population like Finland. Teplizumab has initiated cascade of successful immunotherapies for secondary and tertiary prevention. Although identifying eligible population is still problem to be solved. Like for example, are you going to screen the entire population for two antibodies, or are you going to restrict that to select number of people? So that's still question that need to be answered. In India, we need to work together to improve quality and longevity of life of people living with type 1 diabetes. Thank you.